we're right at 10 o'clock, so we probably should get started. And I'm sure
Sure.
Bo will be joining us shortly. And we'll go ahead and start. So I'm going to start off by doing some housekeeping stuff here. First of all, um, this is a monthly presentation. We're doing audio-vestibular case medicine discussions. The hosts are myself, Gerard, Gianoli, Mohamed, Hamid, who is currently having some issues with computer trying to get in, and Eugen Ionescu from Lyon. Um, just one big disclaimer, the information discussed is meant solely for educational purposes and not intended as medical advice for any individual. For individual device advice, please seek the counsel of your physician. While these conferences are geared toward medical professionals, patients are welcome. However, we will not discuss individual patient cases in this setting. Please speak with your physician for individualized medical care. And then lastly, we're archiving all of these discussions on our YouTube website, which is AVM Case Discussions. So YouTube.com/at AVM Case Discussions. And so the first case we have here is we have a case of vestibular migraine that I thought would be very interesting to discuss. And this is a patient who, oh my goodness, I'm having trouble with, there we go. She's a 41-year-old lady who presented to me
Hello,
after,
Jerry. Can you hear me?
hey, I'm glad to see you here,
Yes.
Mohammed.
All right. Yes, I'm glad to. All right.
We just got rid of the
I
housekeeping stuff, and we're
yes,
just about the case
yes, I
present.
did. I did hear everything you said. All right. How are you, everybody? Okay.
All right, so we got a 41-year-old patient with a 5-year history of episodic rotary vertigo spells. Her spells would generally last a few seconds per spell, and had been on multiple migraine therapies that have not been helpful for that. In addition, she had just constant unsteadiness and disequilibrium that was almost sort of like a rocking, swaying sensation she would have that would uh, be worsened at times. She had constant pressure headaches that would get, they would wax and wane. Sometimes they were just completely unbearable and usually worse than the vertigo spells from the standpoint of disability. The triggers that she had included straining positional changes in head movements, and those triggers would not just provoke the vertigo spells, but also worsen her headaches. Also, she had bilateral aural fullness, low pitch buzzing tinnitus, and hyperacusis, bilateral pulsatile tinnitus and autophony. Further, she had no hearing loss and reported no fluctuation of hearing. And I'll just let you know up front, her audiogram was stone cold normal. So, which brings me to, I think, the first great discussion questions here are what would be your initial management of a vestibular migraine patient? And I'm going to turn this over to Eugene initially. Eugene, what would you put as your vestibular migraine? Like you got a patient with vestibular migraine. What is the very first thing you're going to do for this patient?
Um, I think that I would start with a preventive treatment of the migraine. Basically, I used to utilize propranolol, the beta blockants, and in case of in case of in case of effectively, if there are no contraindication for this, mainly the asthma or bradycardia, etc. And I have very good results in migraine, in common migraine, associated plus or with eye drops, which might be secondary. But if it's we speak about uh, an association of mania disease with migraine. I used to in a second time 2 or 3 weeks after to take a try with a drain or diuretics in the same times in the affected year, of course.
I'm sorry, Eugene, what'd you say before diuretics? You said something and diuretics?
I would put a drain, a yo-yo, in the affected ear if there are clear symptoms of mania disease associated to the migraine.
Okay. Mohammed, how about yourself?
I'd like to start by saying you already telling us it's a vestibular migraine.
Well, that's
And
been her diagnosis,
Migraine.
for 5 years, and she certainly meets the criteria for vestibular migraine.
um, I'm,
One,
I would have a little bit of second thought about that because the pulsatile tinnitus is definitely not part of vestibular migraine. Pressure by itself is not part of vestibular migraine. And to me, to make it easy for everybody else, vestibular migraine requires the diagnosis of migraine in the first place. So, but be that as it may, with vestibular migraine, the definitely history is important, exam is important. We don't need to do a lot of testing. And we figure out why is it that this patient didn't really respond to the treatment of migraine first. And unlike Eugene,
Can
I
I stop you a
usually
second? Can I stop you a second, Mo?
sure,
Because that's going to
sure.
be my second question is that you're answering. The first question is, what would
Okay.
you do as initial treatment for migraine? Just forget about this patient for a minute.
Oh, okay. For sure. The first line of treatment that nowadays I use is I look at the lifestyle, and then if I must use medication, I will see some of the, let's say, poor sleep, and I give them something like amitriptyline or triptyline.
Okay. Anybody
I
else?
don't use Inderal actually, but it's Inderal is part of the medications. The other medication I sometimes start off with is Topamax, but again, I look at the patient kind of lifestyle and see if the Topamax would fit them better than, for example, the amitriptyline or the nortriptyline.
Anybody else want to add? It looks like Art wants to say something.
I'm gonna respond. I'm on Mohammed's team here. I'm going to respond to your second question because I'm wondering the initial management of vestibular migraine. She's had that like for 5 years. All the different medications have been tried. Perhaps that means that that's not what's going on, and she doesn't. And as I said, or as Mohammed said, she doesn't meet the diagnosis criteria of vestibular migraine set out by the Barani Society. If she has vestibular migraine, that's fine. Vestibular migraine, by definition, is episodic, and in between the episodes, your history. One of those things she did, or one of the things.
Uh-oh, I think we lost you, Art. But I wholeheartedly agree with your comments, and Mo, I don't think she sounds like a typical migrainer either, right from the get-go. But I think, but she was labeled migraine and put on a lot of different migraine treatments. But I don't think in her prior histories, some of her story came out. I think all the doctors heard was, I'm dizzy and I got a headache, is what they heard. So, which brings me to my second question. What would you do next in a case where this patient's been on multiple migraine meds for the past 5 years without benefit? What would you do next?
May I answer?
Yes, indeed.
Yes, I perform an MRI. I would maybe search for another explanation for this headache, maybe for intracranial hypertension essential with no other manifestation.
Okay. Anything else you'd want to do with her?
And yes, I may be in an exam, an ophthalmological assessment, and to try to, if the symptoms are very important, a second time I would try the diuretics.
Okay.
And then effectively, I will search to have the MRI as rapid as possible. However,
Mohamed?
Yeah, I think, yes, I definitely will make sure that I convince myself that she has episodic migraine headaches. Headaches is one thing, and migraine headaches is a different thing. The other thing is, I probably would, I don't, again, I have to read her 5 years record, which I'm sure pretty thick. I would like to get her to actually fill in a migraine diary, maybe for 2 to 3 weeks. And I would do office vestibular exam. I wouldn't get any vestibular testing yet. I definitely agree with Eugene, get an MRI if she hasn't already got one. And revisit with her to really get to the diagnosis.
Anybody else? One of the keys for me when I first spoke with this lady is kind of get back to the migraine diary, is that she is never without a headache, which to me kind of right off the bat tells me this is not a migraine, because migraine's an episodic phenomenon. And if she's
that's a red flag, yes.
Yeah, all the time, it just doesn't fit. Now, sometimes it would be bad enough that she'd want to take an axe to her head or something, but it was always there, which is a big tip off for me. So what I did with her initially, I did order the MRI scan, but I don't have that until the next couple of slides. But I did a workup, a vestibular workup on her, and this is what we found, which I was a little surprised at this. She had a big time left caloric weakness of 58%. She also had a positive left Henneberg's test or fistula test, a positive left Tullio's test, a positive glottic valsalva, and a positive oxygen saturation test, which I'm going to show you guys in a minute, because I'm sure a lot of you guys aren't familiar with the oxygen saturation test. Then her CVAMP test was normal, but her OVAMP test was abnormal, with the left side predominating, with the left-sided asymmetry of 32%. And then her OVAMP at 4,000 hertz was present on the left, which is very abnormal, as you guys know, kind of suggesting a third mobile window disorder. And then the last thing I thought was really impressive about her is her tympanic membrane displacement test was abnormal, and that's our non-invasive test looking at elevated intracranial pressure. So that, again, kind of raises my suspicion of elevated intracranial pressure. So imaging, so on the CAT scan, we're going to look to see, do we have a dehiscence? And I scrutinized her scan. I could not find a dehiscence anywhere. So pretty much normal otic capsule, and did not find anything on the CAT scan. MRI scan didn't show any internal auditory canal or cerebellopontine angle lesions or masses, but it did show some abnormalities elsewhere. Namely, she had a partial empty cella. She had very tortuous optic nerves with CSF extending all the way up through them and having an extended or enlarged optic nerve sheet diameter. Normal is supposed to be like 6 millimeters or less, so these are way out there. But I think what's interesting in this case, this lady actually did have an ophthalmology exam that was normal. And if you look at her globe, she doesn't have any flattening of the globes, and she doesn't have any papillary protrusion. So it wasn't enough to cause ophthalmic problems, if you would. The oxygen saturation test, the one I have alluded to earlier, was we would put just a plain oxygen saturation monitor on the patient's finger and measure their oxygen and their heart rate, or O2 sat and their heart rate while they did the Valsalva. And you can see this is her result. Resting, she's at 98. She does a nasal Valsalva, didn't really change it much, actually went up to 99. Then we have a resting period, and then she does the glottic Valsalva, and she goes from 99% sat down to 91% sat. And at the same time, her heart rate jumped up to 130. And then as soon as she stops the glottic Valsalva, it goes back to normal. And this was reproducible with her. So what I came away with on diagnosis, that she had a left uncompensated vestibulopathy. She had a CT negative third mobile window syndrome. There was no defect identified. And again, I'm like Eugen, I was very suspicious of increased intracranial pressure. And with the positive O2 sat test, I was concerned she might have a right to left cardiac shunt. At this point, I would kind of throw it out there. Is any other diagnostic tests that you guys would suggest, or any other thoughts on diagnoses for this particular patient?
You know, Jerry, I forgot about the straining. She has symptoms with the straining, and that definitely agrees with what Eugen has in mind. Now, with a 53% caloric test, I would expect that this patient should have had a history of true vertigo at some point if that difference is clinically significant. I've seen caloric tests where, you got 60, 70%, and the patient, I dig very hard. Did you ever have merry-go-round vertigo? And if the answer is no, I mean, caloric test is very variable, but the other tests are obviously much more objective.
No, she had rotary vertigo. She did. Okay. She's got episodic rotary vertigo.
All right. Now, here is my question to you and to the panel. Has this ever been documented?
Problem.
We lost you.
We lost you for a second. I think you were saying something. Yeah. Has something been documented?
You know, when people in my practice, when they say, "Oh, I had the worst vertigo of my Meniere yesterday," I say, "Absolutely, come in tomorrow, and if I don't elicit or see spontaneous nystagmus, I don't consider it truly physiologic vertigo."
Well, in this particular lady's case, when she would do her Valsalva, she would get nystagmus. Yeah. And she would get the vertigo. And it pretty much correlated with what she had told me in her history, that she'd get these short episodes of vertigo when she would strain. There were other things that would do it too, but that was the principal trigger for her vertigo spells.
What side to what side the nystagmus was beating Jerry?
I don't have it listed, but I want to say when she would do the Valsalva, it would be to the right side, the opposite of her caloric weakness. But the other thing I thought was interesting with her, because besides the vestibular testing all kind of showing left-sided stuff, she had no real history that suggested for one reason or another that the left side was worse than the right. All of her symptoms, bilateral pulsatile tinnitus, bilateral hyperacusis, that sort of thing. But it was pretty dramatic. I didn't include her rotary chair test, which looked like an uncompensated vestibular loss. But I was convinced she had a left-sided vestibulopathy.
Yeah. I agree with that. I like Mohammed said about the calorics. I'm really glad you did calorics. Calorics are very, very useful for two reasons. First of all, you are lucky enough to be able to get an abnormality. Mohammed said sometimes you can say that, but it's suggestive. Lots of left-sided stuff going on. So you've got an abnormality on the left-hand side. The other advantage or the other help for calorics is sometimes if patients have very, very vague history, or they just say, oh, I've got vertigo. Where'd you learn the word vertigo? Do the calorics on them and then ask them in a non-leading way. You don't say, oh, is this the same as you've got? You say, have you ever felt like this? Oh, this is exactly the feeling I've been trying to tell the doctors for 5 years. This is exactly what I've got. So in addition to whatever else is going on, she has, like you said, I think she's got a poorly compensated vestibulopathy, which appears to be maybe or long-standing, perhaps gradually progressive. You've ruled out a lesion. So it's just for whatever reason, you're left with a poorly compensated vestibulopathy. You've just got to push her, tell her not to worry. From the migraine point of view, I'm not a neurologist, but a lot of neurologists say maybe we should give them a medication holiday. Take them off all the medication, see if that makes any difference to her symptoms, and keep her active and tell her not to worry about it.
I think this is a good point, Art, where patients get the caloric test and really correlated with their own symptoms. So the other thing, Jerry, is what if that 54% is due to hyperactive right response, not necessarily to a normal left response?
I think the thing that kind of weighs against that is the vent responses. Showing a hyperactive response on the left and a positive 4 kilohertz OVEMP. To me, kind of points there's something on the left side.
Okay,
sure.
I mean, I think in isolation, I would totally agree with you, but you put it all together, I would have to say there's something going on there.
Left perilymphatic fistula.
Or basically, or one of these other undiagnosed, dehiscences like a abnormal cochlear IAC patency or something like that. So what I did with her is I went to lower her ICP with acetazolamide, and it made a dramatic improvement in her symptoms. She just hadn't felt so good in so long. And of course, the other thing I told her to do is a little bit of Groucho Marx medicine, where I told her, well, if straining makes you feel bad, don't do that. And that made a huge difference for her as well. And she did quite well for a few months with that, but she slowly started getting more of the head pressure problem. And we eventually did a lumbar puncture on her, and it showed an opening pressure of 24 centimeters of water, which is elevated, but not like really crazy elevated. But we drained her down to, like low teens or 12 centimeters of water. And that gave her dramatic relief in her symptoms, but that only lasted for about 3 or 4 days. The other thing I did was I was going to open it up. Any other suggestions of things to do with her?
Diamox.
Yeah,
Yes.
that's what I have her on. I had her on for a few months and she did extremely well, but it kind of started creeping back. And I would go up on the dose, and eventually we got to the point where the medicine was causing some issues for her. And so now we got a patient who responded to Diamox. She's got some elevated pressure. She's got signs on her scan of elevated pressure. And we're looking for what do we do next?
Gary, did you look after the diameter of the longitudinal sinus? Because sometimes there are some cases in literature with patient with dizziness, pulsatile tinnitus, bilateral, and in fact they have a longitudinal sinus where is the resorption of the cephalorachidine liquid. And there is in section, the superior longitudinal sinus have a little diameter. And I think that there are some possibilities to verify the flow. And there are some teams in Switzerland and in Germany, I think, that they stented the longitudinal sinus with very good results.
I have to admit, I'm not sure I understand what you're referring to, the longitudinal sinus.
So this is the longitudinal sinus in this and
Lateral ventricles?
No, no. The great vein at the longitudinal sinus.
The transverse sinus.
Yeah, transversal.
Transverse sinus.
Transversal sinus. Yeah.
Yeah. We did do MRV on her, and that came up normal.
Okay.
That was one thing we did do. I totally agree. That's something I kind of routinely do, and I should have had included that in the slides, but that would turn out to be normal.
Okay.
Anything else?
Jerry, how high did you go on that?
With the Diamox?
Yes.
I think we got up to about 2 grams a day.
Yeah, that's a pretty good dose. Some people would even go to about 3.
And I was willing to do that, except she was starting to get so fatigued on it that what I'll do is if they get fatigued, I'll say, okay, well, let's just hold off for a while. Let's see if you can adjust to that before we go up to the next level. And she just never adjusted. Although the Diamox allayed her symptoms, she was starting to get just as miserable from being so fatigued from the Diamox.
Yeah.
So
I also think
again a problem.
I mean, I have to see the say 2,000 Diamox plus Topamax or alternate with Topamax, because Topamax is a carbonic anhydrase inhibitor as well.
Yeah, I've tried that before as well. I didn't do it in this case, but I think that's a good option too. Yeah. I think somebody, is it Magda Elkalini wants to make a comment?
Yes. This is Dr. Elkalini. I'm actually, I know Dr. Hamid for a long time, and he invited me several times to your. How are you? It was nice to see you. So this is a very, very nice discussion. I think I have a case like that. It was diagnosed as vestibular migraine, and then we found out that the patient having increased CSF pressure. So I ended up shunting her. And based on the fact that the patient got better with the Diamox and with the spinal tap, just the spinal tap improving the vestibular migraine or vestibular headaches, I think it raises the issue of should we put a lumboperitoneal shunt. And I think if the symptoms are definitely better with the medicine and with the spinal tap, I think a lumboperitoneal shunt will help a lot. But this is very interesting. That I think the fact that the MRV should be done for these patients all the time, because especially if their pressure is high, just to rule out the possibility that might be a stenosis of the sinus, transverse sinus, or usually at the transverse sinus or the junction of the transverse sinus with the sigmoid sinus. And the stenting of these sinuses would help these patients and avoid surgery. So this is the only...
Totally agree with you, Dr. Elkalini. Actually, we discussed a shunt with her, and we went back and forth on that issue as well. Someone just asked a question about ECOG. ECOG actually was done in this case. That's a great question, and it was normal. What we did was the next thing was we had a cardiology evaluation. And she
Jerry, can I just ask Magdi one more question? Magdi, this is very good input. My question to you is, when do we consider sending patients to neurosurgery?
If the patient had a spinal tap and the spinal tap showed that the pressure is high,
It's
and
elevated.
high pressure is different for different patients. Some patients 24 is very high for them. Some patients 24 is normal for them. So usually anything more than 20, okay, very suggestive. And sometimes I have a patient that they have pressure of 20, which is considered normal in some patients. It's actually considered abnormal in other patients. So in any way, if the patient shows that there is some improvement of lumbar puncture and spinal tap, I think this patient should be sent to a neurosurgeon.
I think that's a great
Thank
comment.
Yeah.
Yeah.
One of my pet peeves is what is normal CSF pressure? And I don't think we know, because I have some patients that I have this one patient in particular who comes down, we do a lumbar puncture on her about every 6 to 12 months. And she normally, her pressure will be about 18 when we do her opening pressure, but she feels so much better when it's 11. And she will tell.
Yes, that's what I'm.
Yeah, she just
Yes, that's what I'm
feels
saying.
Yeah.
That. Yeah. So the pressure is. I have a patient that the pressure was actually 18, and the patient was having bilateral papilledema. Okay, even
wow.
to that extent. So 18 sometimes is considered high for certain patients. What's the BMI of this patient?
Oh, she had a normal BMI. I don't remember what it was. She
BMI.
wasn't overweight. You know, I mean, I
Okay.
would guess, if I had to guess, it was probably about a 24 BMI.
Especially you showed the MRI with the empty cella. Okay, so empty cella syndrome, you should do a spinal tap for any patient that had empty cella and having symptoms of whatever the symptoms are. If I see empty cella and the patient is having headaches, okay, I will send him for fundus examination. Be sure that they have they don't have papilledema, and I measure their pressure. So empty cella syndrome is very important to see. And also you showed the optic nerves. Okay, so this is a case of increased intracranial pressure. Even this pressure is not that high, but I think in her case, I think it's high for that patient.
Totally agree. Totally agree. So she got a cardiology evaluation where she had a transesophageal echocardiogram with a bubble test that confirmed she had a patent foramen ovale. And we actually went back and forth on whether that should be repaired. And she eventually got to the point where she was getting short of breath because of the patent foramen ovale, and had it repaired. And then almost instantly, all of her headache, vestibular symptoms completely went away. And we
Impressive.
discontinued her Diamox. And that was about a year ago. I spoke with her not too long ago, but she's been completely off of everything and asymptomatic for the past year since she had her patent foramen ovale fixed.
Holy smokes.
So I think this would raise the possibility that there is some relationship between the patent foramen ovale and increased intracranial pressure.
Absolutely. That was my supposition. And I put this little slide together just for folks who may be not as familiar with patent foramen ovale, but it's potentially present in 25% of the population, and it's usually harmless or asymptomatic. And what happens is when the pressure in the right atrium gets too high, it can open up and cause venous blood to get pushed over into the left atrium. And so you've got deoxygenated and high carbon dioxide saturated blood going into the arterial system, which then gets distributed to the brain. CO2 is one of your biggest causes for cerebral vasodilation, which would then increase intracranial pressure and cause headaches. And I think that's what was the scenario in this lady's case. And once you stop the dumping of all that CO2 into the arterial system, it got better. Now, what patent foraminal valleys are most infamous for are the paradoxical strokes, where someone is young, healthy person, no arterial disease, and they'll get like a blood clot in their leg that will then go up and cause a stroke, and it just passes through that patent foraminal valley. We see it also in otology and divers with inner ear
Yeah.
decompression.
Yeah.
And I've had a few of those. And then more recently, it's been implicated in the cause for migraines and specifically for vestibular migraines. And to be honest with you, I started checking for this routinely whenever we do a Valsalva test about 15 years ago. But anytime I had an abnormal test and I'd send them to the cardiologist, they'd like, they got a patent foraminal valley. We're not going to do anything. Just put them on aspirin and that's it. And I have eventually got to the point where why do I send them to the cardiologist if they're just going to put them on aspirin? And I kind of stopped sending them to the cardiologist. And then more recently, I've noticed in the cardiology literature, they've gotten more aggressive in treating patent foraminal valleys. And this lady is one example. I have another patient who I've diagnosed this with, and I've got her on Diamox as well. And so the cardiologist, basically confirmed she had a patent foraminal valley, and she was like, "Well, are we going to repair it?" And his response was, "Well, why should we repair it? You're asymptomatic now. If you become symptomatic, then we'll talk about repair," which I think is a very reasonable, way to approach it. But there are a couple of articles out there on using repair of patent foraminal valley for treatment of specifically vestibular migraines and more broadly migraines in general, which I think is just fascinating. Any comments about that?
Can you send us these articles?
Oh yeah, I can certainly post those. I tell you what I'll do
Yes.
is when I post the recording on YouTube, I'll put the references in the comment section for those.
Yes.
And Gary, did you try to see if the Tullio phenomenon was still present after?
Yeah, no, I did
Surgery.
not. Yeah, I have to admit, I'm kind of a pragmatic guy in that
Okay.
the patient tells me they're fine. I'm not going to do it.
I, I think you should do it.
I
Good
don't ask.
point, Dean.
That's
So-
okay. Yeah.
Yeah, she tells me sound doesn't bother her anymore. She doesn't get the headaches, no vertigo. So I take her at her word, and I don't want to tempt fate, especially with somebody like that who's had such a hard go of it. You hate to have her, have any backsliding at all.
I
Okay,
think
political question, Jerry. I'm sure at least I would venture to say 5 to perhaps 8 physicians saw this patient before.
Oh yeah, no, easily. I mean, I can't tell you who, but
You
can
saw
tell you-
her, correct?
Yeah. Oh yeah, she's seen by a ton of people. Yeah.
How are we gonna fix that?
I personally think what happens is, our medical system has gotten overloaded with patients, and doctors have 5 minutes to see somebody. And this lady comes in and she gives a story. She's got a headache and she's dizzy, and that's all the doctors are hearing. And they don't kind of get the whole story like I've laid out for you guys. And they get sent in, okay, and if the MRI is sent for IACs, a lot of times the radiologist is not going to look at the sala or the optic nerves, because I've seen those before too, where it's like, oh, normal, no IACs are normal, no acoustic neuroma, and it's because the radiologists have the same situation. They got 30 seconds to look at the MRI scan, and unless you point out to them, hey, does this patient look like they might have elevated ICP, you're going to get a different response from the radiologist. than if you're just saying, okay, make sure it doesn't have an acoustic neuroma.
I know, but even regular ENT, when they see patients like this, and let's take the empty cellar syndrome, that probably won't do anything about it.
Yeah, there was interesting in preparation. I'm actually going to do a forum for the ANS in the fall on elevated intracranial pressure, and kind of in preparation for that, I was looking for literature on what is normal ICP. What is normal CSF pressure with an LP. And back when I was in medical school, it was the upper limit of normal was 18. But
Yeah.
there's some people suggesting 30 is normal. And they're basing that on whether or not they have papilledema. But I think the biggest problem there is most of these folks can be affected by it and have no papilledema. Like this lady is a good example of that. And I don't think that's a great way of determining whether someone's pressure's too high or not. I think, like Dr. Elcolini mentioned, some people have quote unquote normal pressure, but it's too high for them. And I think we have to individualize every case.
And I think the reason why that some patients, they don't have papilledema because of the anatomy of the subarachnoid space around the optic nerves. So these spaces sometimes is obliterated, and that does not allow the pressure to be transferred to the optic nerves and the optic disc. And sometimes you don't see the papilledema. So I think this is very important also to investigate and to mention.
I think another thing to think about too is when you look at the MRI scan, you're not seeing pressure. What you're seeing is the anatomic changes due to pressure. And at least in the studies I've looked at, even after the pressure is brought down to normal, those anatomic changes stay. The only one that kind of reverses a little bit is the optic nerve sheath diameter will get smaller, but the empty cella stays, and a lot of the other things that you'll see will be persistent. So it's kind of like it shows you almost the past, not the current situation. Whereas when it comes to the ear, I think intermittent episodes of pressure can be devastating, and much more so than it can be to the eyes.
Yeah, very good point, Jerry. And Magdi, we're going to be shipping patients to Kentucky very soon.
No, I have my humble experience for some patients, but the lesson that we need to learn from this case is the foramen valley. Okay, I'm gonna go and get that patient that I did the lumboperitoneal shunt and I did a study because I never did that. Okay, so I think this will open. I think it should be written, and this case should be written, and this issue should be written. So you guys, this is a very, very impressive discussion.
We've been doing kind of for the last, I guess maybe the last 4 years, I've pretty much routinely been doing the O2 sat. Like I said, we started doing it 15 years ago, and then I kind of stopped doing it. But we started doing it about 4 years ago, and they periodically will pop up. Of course, one of the issues with the O2 SAT test that we do, it has a lot to do with how vigorous the patient strains. So if they strain just a little bit, you might not get it. If they strain really hard, you're more likely to see it. But at least in anatomic studies, it's as much as 25% of the population, with the younger population more predominating than the older population.
Great case. So what surgery for migraine now we should consider?
Well, the closure of the pain-foraminal valley is one, and I guess the shunt, the ventricular shunt is the other.
All right.
All right.
Great case, Gerard. Thank you.
Yeah.
Thank you very much.
I think that the discussion was very, very interesting because We have sometimes we saw the patient, we have a progressive hydrocephalia, but with no symptoms. What we call this hydrocephalias with the normal pressure. But what is the normal pressure? I think the discussion we had now and the reflection of Dr. Ercalini are very interesting, because I think that this is a person which has had, however, migrainous terrain, but with the problem, with the issue of this cardiac problem, there are some regulation. The system. There are hormones which will regulate not only the blood pressure, but also the secretion of the endolymphatic and the LCR, and that might explain what even the ECOG was normal with not modification, but there might be a relation between the production of the LCR, of the liquid cephalorachidian liquid, and the symptoms, because there was however some clear and net symptoms of the inner ear, whether on the left side, but also maybe on the right side. It's a very challenging subject.
I wouldn't even use the word migraine with this patient.
Yeah.
Her headaches were due to increased intracranial pressure.
I think that's a great point. I mean, she really is a migraine patient.
But my question is how we can find a relationship between that CSF pressure or CSF and the vestibular system in the ears. I mean, how can we investigate that? There is any imaging study or any test that can show that? I don't know.
Yes, in France there is a device which it's called Ecodia system, and the Ecodia system use the spontaneous or provoked autoemissions, and in case of raised intracranial pressure, there is a shifting of the autoemission, and indirectly we can say that it's a Meniere disease, or there are some studies in where when the intracranial pressure is raised, and we can see it on the echo with this device. But there are some work to do still, and we have no. There are no studies very well defined for this.
You know, the other thought too is the MRI hydrops protocol has shown there's a lot of folks with hydrops that we can see on MRI scan that we wouldn't have necessarily thought. And the unfortunate thing is most hydrops protocol require like a 4-hour contrast placement, 4-hour delay imaging. But there's a new protocol I just read about where you don't need to wait 4 hours that's supposed to give us a real good imaging for hydrops. And I think that's going to probably eventually supplant for looking at, endolymphatic hydrops for sure, or Meniere's disease.
Yeah.
Actually really interesting, because such a constellation of symptoms. And I found one paper here from a Chinese group. It's most common in females between 45 and 55, and they list all the different symptoms, basically everything you said. So if you think about it by Occam's razor, you want to look for one explanation rather than 5 explanations. Maybe that one explanation is the sort of classic PFO presentation. And that's good. Whoever did the esophageal, the DEE was really bang on. And again, talk to a neurosurgeon or a cardiologist about this, but it looks like it's a sort of a classic case. And again, you want to simplify it down. So Occam's razor says, okay, let's look for something which will cause all these different things. And PFO is written in the literature as one of those things. So, like Mohamed said, fascinating case.
So someone, Iona Boda, I apologize if I'm mispronouncing your name, mentioned that,
Hello, Iona.
Mentioned that PFO does not directly cause increased intracranial pressure. And I was curious about that. So I actually researched that as well. And no one's actually directly looked at that. And although no one has ever claimed that it can cause it, but no one's actually directly looked at it. And so the other question went in my mind with this particular case is this a lady who had somewhat elevated pressure and then the PFO just aggravated it, in which case it became something more than it would have been otherwise. But that's a study that is yet to be done as far as I've looked. And I actually spent a bit before this conference looking for that. But PFO can permit venous emboli, and absolutely, I totally agree. And that's one of the big things. As a matter of fact, back when I started referring patients for this, the cardiologists weren't interested unless the patient had a stroke beforehand. But I read an editorial in one of the cardiology journals recently where someone was arguing for doing PFO closures even in asymptomatic patients because of the concern of a stroke. And just kind of like totally reversing, want to be much more aggressive in treating these folks.
Jeez.
But the PCO2 should be elevated in symptomatic PFO.
I'm sorry, say again?
The arterial CO2 should be significantly elevated in open symptomatic PFO.
Oh, that would be my understanding. And it just makes sense because one of the biggest instigators for cerebral vasodilation is arterial CO2 level. I mean, it's one of the reasons we hyperventilate patients when they've had head trauma is to lower their CO2 level. To me, I find it amazing no one's actually looked at that yet. Hey, that's a great study if somebody wants to look for a study out there.
Jerry, I have to say this is a great case for a little bit more message to everybody out there that when patients presenting with headache, dizziness, and this and that is not really very clear, don't just send them straight to vestibular rehab, on which a lot of primary care physicians and general ENT physicians do. I know I'm addressing a political point here. Just like the case I presented a month ago where somebody went to vestibular rehab for 6 months with a brain tumor.
Right.
Yeah, that was kind of my question as a vestibular therapist. Good morning. My name is Morgan.
Hey, Morgan.
Would we expect that we would see compensation out of this patient, especially with that type of weakness? What would be a prognosis for vestibular recovery unless they had this procedure?
My thought, and she had been through, I didn't put in there, but she had been through vestibular rehab at some point. But this is somebody that would probably get some partial response and then relapse, and then get partial response and relapse. Basically, every time she would injure her ear again. Now, it obviously wouldn't change the headaches. Probably would not change that constant rocking sensation, but would probably get some benefit. My goal for most of these folks is typically you get them stabilized, whether it's medically or surgically, and then you do the vestibular rehab afterwards. And I didn't put this in there, but I did after her PFO, we did do some vestibular rehab afterwards.
And for clarification, do we think that the PFO created the hypofunction?
You know,
And is
that's,
it coincidence it's on the left side, given the anatomy?
yeah, so I think that's a great question too. There's a couple of potential theories. I think, you know, did she have endolymphatic hydrops on that side that was not enough to cause an abnormal ECOG? Did she, as Mo was mentioning, did she have an intermittent perilymph fistula that caused it? I think there's a couple of different possibilities. Given that when she would strain, she would provoke the nystagmus, I'm more inclined to believe there was probably, you know, intermittent perilymph fistula, or either
The other
some,
thing, yeah,
some.
the 54%, sorry, Jerry, go ahead.
Go ahead, Mo.
No, I'm saying that the 54% caloric asymmetry is not really that majorly different. And again, we should not treat the caloric numbers. We should really treat the patient's symptoms. And in this case, she had intermittent change in the inner ear fluid primarily.
All right. Any other questions, guys?
No, thank you, Jerry. This is really excellent case. Thank you very much for presenting it.
So we have our next meeting is going to be Friday, August 8th. And the illustrious Dr. Mohamed Hamid is going to talk about a case regarding vestibular imbalance rehab, when not, and what options. So hopefully everybody can join us then. I have to say for myself, I've enjoyed doing these. I enjoy the interaction with all you folks, and please, you know, anybody that wants to make comments and such. Oh, we got more comments. Before we close, we should go through the comments because we still have a few minutes. Did any venous sinus hypoplasia, was that ruled out? Yes, it was. There was a MRV that was done. There's well-established association between patients' patent foraminal valley and thrombophilia, especially in context of paradoxical emboli and cryptogenic stroke. Yes, I'm familiar with that as well. I put in, I guess that's it. That's all the questions. The rest are just comments. But, you know, of course, the big thing to concern with PFOs is the stroke. And I think putting the patient on aspirin at the very minimum is a reasonable thing to do. Anyway, so we'll see you guys in a month on Friday, August 8th, same time, same channel. And keep in mind, we're going to archive these videos on our YouTube website if anybody wants to check them out, and I will include those references. And I think one of them is the one you mentioned, Art, that I had seen.
Oh, great. Okay. Yeah, it seems to be quite an extensive study that was done. So I'll have a look at it, read it fully, read all of them. That's great. Thanks, Jerry.
All right,
thank you very much. Thanks, Maggie, for attending.
Thank you very much.
Thank you very much.
Thank you. Yeah.
Super.
Thank you.
Hi, guys.
Have a nice afternoon, everybody.
Thank you.
Good work, my friend. Excellent.
Good. Okay.